Hello and welcome to today's question and answer webinar with the authors of the BFRB Recovery Workbook. My name is Jolie Busby and I'm the Education and Training Manager here at ADAA. A little housekeeping for today's session. This webinar is being recorded. Closed captioning and translation are available. Attendees at today's session will receive a link to the recording within 48 hours. This webinar will use the Q&A or question and answer feature that you should find close to your chat icon. We'd ask all of our participants to ask the questions through the Q&A feature, and we will attempt to address everyone's questions in the time allowed. We will start with questions that were presented to us in advance at the time of registration. So now I am very pleased to introduce our moderator, Dr. Tamara Gordon.
Hello, everyone. Welcome. I'm so glad to be here with Drs. Reinardy and Deibler. I am a clinical psychologist and director of the Gordon Therapy Group in Manhattan, and also the vice chair of the OCD special interest group at ADAA, which is how I come to be here participating with all of you. I'd like to just introduce our speakers. Dr. Renae Reinardy is a licensed psychologist and director of the Lakeside Center for Behavioral Change. Dr. Reinardy specializes in the treatment of obsessive compulsive disorder, body-focused repetitive behaviors, and related conditions. She's the program developer of CourageCritters.com, a skills-focused online and plush animal system. Dr. Reinardy serves on the BTTI faculty for the International OCD Foundation and the PTI faculty and board member for the TLC Foundation for Body-Focused Repetitive Behaviors. She's been interviewed on Good Morning America, North Dakota Today, and The Joy Behar Show. Her treatment techniques were featured on Dateline NBC and A&E's Borders. We're so happy to have her. Dr. Marla Deibler is a licensed clinical psychologist and the founder and executive director of the Center for Emotional Health of Greater Philadelphia, a multi-site behavioral health care center specializing in the evaluation and evidence-based treatment of anxiety disorders, obsessive compulsive and related disorders, and neurodevelopmental disorders. Dr. Deibler currently serves on the faculty of the Behavior Therapy Training Institute, the BTTI, of the International OCD Foundation. She serves as the president of the board of directors of OCD New Jersey affiliate of the International OCD Foundation, and as a consultant on behalf of the New Jersey Center for Tourette Syndrome and Associated Disorders. Visiting clinical supervisor at the Rutgers University Psychological Services Clinic, and as an executive council member of the Association for Contextual Behavioral Science, OCD and Related Disorders Special Interest Group. So we have very esteemed and accomplished presenters here today for all of you. And it is really neat to be here with the two of you to talk about BFRBs. Why don't we get started maybe by just kind of if one of you could maybe just take a minute to talk a little bit about what a BFRB is, and also maybe what it isn't.
Yeah, sure. Thank you. My screen all changed. Now it's back to normal again. Sorry for the pause. So it's wonderful to be here. Dr. Deibler and I go way back. I was looking at it. I think it's since 1998, we first met, and since 1999, soon after meeting, we've been involved in the treatment of body-focused repetitive behaviors and developing integrative treatment models to help improve clinical outcomes for individuals experiencing BFRBs. And when we look at what is a body-focused repetitive behavior, we tend to think mostly of compulsive hair pulling, compulsive skin picking, nail biting, but it even goes beyond that to look at lip biting behavior, cheek chewing behaviors, basically anywhere we have hair, skin, nails, and we start engaging in what's oftentimes referred to as over-grooming. And these are things that are not just seen within humans, but we also see them in primates, cats, dogs, horses, even fish can engage in behaviors that look a lot like body focused repetitive behaviors in us humans. And so, and I think that that's a great question. What is it? What isn't it? And I'll leave maybe the what isn't it to Dr. Deibler, since she's written some great articles on that with self-injurious behavior, things along those lines. But in general, with BFRBs, we're talking about hair pulling, skin picking, nail biting. That's what most of the literature will discuss, but it goes beyond that as well.
And in terms of what it isn't, body-focused repetitive behaviors are not considered to be self-injurious behaviors. They serve a different function and they respond differently to treatment. So they are not self-injurious, although they might result in injury. They're not considered to be non-suicidal self-injury or self-injurious behavior. They're not goal-directed in that same manner. They're also not obsessive compulsive disorder. Although initially in studying BFRBs in the early days of looking at trichotillomania, they were really looking at hair pulling within groups of individuals who were reporting OCD, because trichotillomania was not yet studied as an individual group. And so it was looked at initially as what is essentially now we know to be a comorbidity, but then perhaps a subtype of OCD, at least initially in the beginning, in the early days of trying to understand and conceptualize this behavior. But now we know that these are related and that they are more likely to occur in the same population, but they are by no means the same disorder. They require different kinds of treatments. They don't respond to the same way to medications. And so although they are related, they're more like cousins than they are siblings. And I think those are probably the main two hallmark examples of what BFRBs are not.
You mentioned a couple of things that I want to pick up on, which are great lead-offs into a few more of the questions that we have for today. When you said the function is different than self-injurious behaviors, right? And I think a lot of people do have a question about what is the function of a BFRB? Why do people do this? Why do we overgroom? Why do we hair pull, skin pick, etc.? And then after that is sort of the next question in the queue, if you will, is you mentioned that it's a different intervention than it is for OCD, both psychopharmacologically and also in terms of the CBT for it, or the therapeutic approach for it. So maybe you could both speak to those two, if that's okay.
Well, and I think that whenever we're looking at a behavior, and especially a behavior like BFRBs, that can serve many different types of functions, both within that individual and certainly between individuals, we have to do a functional behavioral analysis to try to determine what is the function of that behavior. And Dr. Deibler can talk more to this about differentiating between self-injurious behaviors and body-focused repetitive behaviors. But when we look at BFRBs and the function that they're serving for people, we want to look at a lot of different elements of that, doing a very thorough assessment, because these behaviors are complicated. No two people are alike, and even within the same individual, the function that BFRB might be serving for them right now in this moment might be different than what it was a year ago, and might be different from what it's going to be 3 months from now. And so we really want to be able to understand that it's serving some sort of function for somebody. So some way to maybe regulate. And the other thing too that we want to look at as far as treatment goes is understanding the comorbidity. We see quite a bit of comorbidities with people with hair pulling, skin picking, nail biting. And while there hasn't yet been any medication specifically tailored to a BFRBs, sometimes medications can be helpful to deal with those. Often those medications can be helpful for dealing with the co-occurring conditions. And that's why Dr. Deibler and I really lean into, in our training, is an integrative psychotherapy, because how wonderful to be able to have this foundation in one particular theoretical orientation, which we lean a little bit more on the cognitive behavioral side of it, being able to build out that conceptualization, but also not being so limited to not be able to draw upon, these other things that we know are empirically validated treatments. Wonderful things like acceptance and commitment therapy, dialectical behavioral therapy, being able able to have people, and I think the unique thing with BFRB is that we often will collaborate with people of other professions too. I work very closely with a lot of dermatologists and wound care specialists to help people with body focused repetitive behavior so that they're getting the medical care that they need in addition to the emotional care that they need. And so, so I think BFRBs bring up a lot of unique things when it comes to treatment and what treatment looks like for each individual.
Yeah, I think that's very well stated. The function is different for everyone, and that's why it's really important to look at each individual's case and each individual's behavior pattern. It's a really heterogeneous set of behaviors. It's really experienced differently for every person, and it serves a different function for every person. And I should say functions because that it might be more than one function. That function might change over time. It might be context dependent, and so that's why it's really important to really kind of take a deep dive into understanding the functional analysis so that we can come up with interventions specifically targeted to, try to manage those antecedents most effectively.
So speaking about antecedents, I think one of the questions that's come up several times is what types of interventions do work, right? So I know you've both spoken that the function's different for every person, the reasons people pick or how they, in what contexts or situations they might careful or pick more are going to be changing from individual to individual. But then what are some of the approaches that we take therapeutically, and also to what degree can we actually, what degree of remission can people get to? How much better can this get?
I think you brought up several great points there. And I think that, talking about expectations in treatment is really, really important. And oftentimes when we look at, like on my intake form, I have people write down your name, date of birth, address, what's your goal in treatment, right? So, and oftentimes people will write, stop picking, stop pulling. I have one client that wrote cure, right? So recently on their intake, I think that it's really important to look at people's expectations in treatment. BFRBs are oftentimes chronic conditions. That doesn't mean that you're hopelessly going to suffer the rest of your life with a BFRB, but it's important to understand that it's probably a part of you, and that's okay, right? So it's trying to understand your BFRB in a different way, forming a different type of relationship with your BFRB. So kind of a metaphor or example that I use with people is don't think of your BFRB as an enemy. Think of your BFRB that's showing up as a friend in your nervous system, is trying to alert you to something. Dr. Deibler and I always talk about BFRBs being both a signaling system and a response system, so that when your BFRB is showing up, it's kind of that friend in your nervous system being like, hello, we need something, right? So, and we have to be able to understand what that is. Okay. So just like how our body signals us for other things, like if my stomach growls right now, it's my body telling me that I need something, I'm hungry, I need food, right? So, and how I fill myself up, is also important, how we feel that need. So I can fill up on chocolate brownies, right? Like that tastes really good, much like a BFRB. BFRBs are short-term consequences, usually very enjoyable. It feels good. It feels right to be engaged in a BFRB. Now, the longer-term consequences tend not to be experienced so favorably, and people feel shame and guilt and, more negative emotions typically. So we want to break all of that down. We have to look at what is your body telling you, and that's part of the functional behavioral analysis. We look at those antecedents, we look at those triggers, we look at those emotional vulnerability factors. In 2006, I wrote an article called Treating the Whole Person, and I talked about sleep, exercise, nutrition, substances, all of these things that are mentioned in dialectical behavioral therapy. They just shorten our fuse. If we're not sleeping and we're living off of Mountain Dew and Doritos, guess what? We're not going to be feeling that well. And guess who's going to show up? Our BFRB to alert us of that, right? So, and then when we engage in the pulling, we're engaging in the filling up on chocolate brownies. It works kind of in the moment, tastes good, but we're not actually getting the nutrients that we need to change this pattern. And that's what we look at with that functional behavioral analysis. We try to kind of figure out the code for what our BFRB is trying to tell us, what our internal needs are. So we look at those emotional vulnerability factors. We look at, again, all the sleep, exercise, nutrition, screen time, all of those things. We look at people's thought patterns and what's involved with that. What are they telling themselves? We look at their relationships. We look at their sensory needs. So Dr. Deibler can talk more about this too, but we have an acronym called TIMES MAP, and that just kind of helps to look at what are the thoughts, images, memories, emotions, sensations that are going on, and the map. What are the things, what are the contextual factors that kind of set the stage for those times, right? So what is, your movement and automaticity? How much awareness do you have of this? Awareness of those vulnerability factors, people, places, the spaces that you find yourself in. These things are also important. And so, and once we have a better idea of those antecedents, what the triggers are, we look at the behavior itself, the B of the ABCs, right? So in which ways are the behaviors carried out? So what does the search look like, first of all, right? So what's involved with that? Is there, are you aware? Are you not aware? Are you touching your hair? Are you looking for split ends or kind of coarse hairs, white hairs? When you're touching your skin, what are you noticing? Are you feeling bumps? Are you feeling rough spots on your lip? Is it rough spots on your cheek or on your tongue? What are you noticing with that? And then how is the behavior carried out in and of itself? So, so if I'm biting my nails, what I feel that search, and then what does that look like? Am I looking at it? Is there a pattern that goes behind that behavior? Like with hair pulling too, maybe it starts with that search. Maybe I pull one hair at a time. Maybe I bite off the hair root, wrap the hair around my tongue. And we want to look at what happens, and that's kind of going into the third part of the behavior. What happens afterwards? Sometimes people pick and flick. Sometimes people pull and dump. So, but oftentimes people do something with that hair, skin, or nail afterwards. And we want to take a look at that. What function might that be serving for them? Now, the only caution is when people swallow long hairs that can lead to a trichobezoar, a hairball in the belly. Dr. Deibler and I have both worked with people over the years. It's not very common, but it does happen, and it can be a very serious medical condition. So if I'm working with an individual that swallows long hairs, I'm going to collaborate with their doctor or their gastroenterologist to see if they have a bezoar in their belly, that if it's small enough, it can be extracted sometimes through endoscopy, but when they're larger, sometimes people require surgery. It's also important to note, if somebody has surgery to remove a trichobezoar, it doesn't mean that they've received treatment for their body-focused repetitive behavior. I've worked with situations and individuals in the past where I've worked with a child, and maybe they were referred to me after a bezoar, and the parents are like, oh, well, we decided we should just probably meet because that wasn't any fun. They probably won't do that again. It's like, well, no, it's kind of like treating alcoholism by giving DWIs. It just doesn't really work. You have to look at what's contributing, what's going on there. So even though it's unpleasant to have surgery, that the person still hasn't received treatment. And so we want to look at all those behaviors. We want to look at the consequences of those behaviors, both short-term and long-term consequences, right? So short-term, like I mentioned before, is often favorable, feels good, feels like the right thing. It's the chocolate brownies, right? So, but long-term, we really didn't give our body what we need, and we tend to feel shame and guilt, which then we kind of circle back again. That shame and guilt then can be a trigger for more BFRBs, right? We go hide in our bedroom feeling bad about ourselves. So, and we give up. We start having self-defeating thoughts. I can't do this. I'm a loser. Like all that stuff comes up, makes us think. That friend shows up to try to lift us up, giving something short term, and around we go. And so it's important to understand that cyclical nature that goes along with the functional behavioral analysis. And this is all important for helping people to understand, to just come in and be like, well, I'm just going to stop. right? So I'm just going to use my willpower. Well, probably going to take a little more than that. So, and I think that's why people get frustrated is, we got to assess readiness. We have to assess those expectations that people have, set them up for success. Look at the strategies, the chicken and the broccoli, and the strategies that really give them the what they truly need to heal themselves. And BFRBs can be a gift in that way, because sometimes people maybe wouldn't have come into treatment to work on that other stuff, but they've come into treatment because their BFRB has been distressing for them. And then that allows us to work on the things that are going on underneath.
Yeah, and what does it mean to heal, right? We use the term recovery in the workbook title intentionally, but also with the understanding that that means a lot of different things for a lot of different people. And it's really important to examine not just what the treatment goals are, but what does it mean to be well, right? What does that look like for you as someone with a BFRB? And, what exactly is the target here? And it's important to sort of look at, how one defines recovered, right? What does treatment success look like? Because that's going to mean different things to different people. And we want people to be able to start at a place of aiming to, play to their strengths, right? How do you want your life to look? Not like these are what I don't want, right? I don't want to pull, I don't want to pick, I don't want to bite. It's easy to say those things coming into treatment because we're distressed, but what do they want? Do they want to live a life that's, unfettered by the shame that they have regarding their BFRB? Do they want to be able to go out and do things that they typically feel self-conscious about doing for fear that they might be discovered in terms of the behavior that they engage in, and then have to explain, if asked, what exactly does it look like to live the life that they want to be living, whether or not the BFRB is showing up? We want them to be able to manage those thoughts and feelings and expectations from the outset, whether or not their BFRB shows up on any given day.
Thank you both for that thoughtful and complex answer to the questions. I think what I'm hearing is that a BFRB is both a symptom of emotional something, right? Emotional something going on, and also a way that people maybe soothe those emotions or make themselves feel better. It feels good to do it, right? And so part of treatment is figuring out what the circle is between the emotions that might be a piece of the BFRB or a trigger for the BFRB, and then also other alternatives or other ways of soothing those emotions. One of the questions that came in while you were speaking was, if you could give just a couple of examples of common functions, right? Which might just be, sort of what we just said, but maybe you could give a little example, like a de-identified case example of something that people say, like, when this happens, I really go to town on my skin or my hair, for example. I think that would be a helpful way for people to understand it.
And while again, everybody's different, and then the things that we want to keep in mind is for people struggling with the BFRB, or for clinicians who are trying to help their clients with BFRBs, we have to do the self-monitoring to begin with. We have to increase awareness. We have to know, when we're doing the behavior, and start kind of being curious about the function that might serve. Often we do find that it's serving some sort of emotional regulation, right? So it's a way to deal with that feeling unsettled, and that can mean a few different things. I'll see a common symptom that I'll see, a common antecedent, is when people get home from work or school, they had a big day, right? So and they come home and they just want to like veg out for a little while. They just want to calm down. They just want to process their day or escape from their day. And they might sit on the couch or sit on their bed, or go right into the bathroom and lean into the mirror, right? So, and start engaging in their BFRB as a way to distract, as a way to try to, calm themselves from their day. So, and when we kind of look at that, to be able, like, okay, what are the people, places, and spaces? It's like, okay, I go to my bed, I go to my bathroom, all right? Then we want to be aware, and when is it? What time of day? So we want to look at the when, where, why, how, who, right? All of those factors that go along with this, because then we can break that chain a little bit. So Dr. Deibler and I in the book talk about chain analysis too. And the sooner that we can jump on board, if I know through my self-monitoring that that's when my BFRB is most likely to occur, maybe I change my pattern before I'm standing in the bathroom looking at the mirror, engaging in my eyelash pulling. Maybe I go back a couple of links in that chain. Maybe I don't go home immediately after work. Maybe, when I get home, I grab my dog and I go for a walk instead of going into the bathroom. How can I meet that function of winding down or calming down or whatever in a different way? Might be an example of what we look at. Or, being able to recognize our emotions. A lot of times too, what Dr. Deibler and I will do with folks is just, people have gotten so accustomed in our society of just shutting emotions off, right? Going into autopilot, not even recognizing ourselves, just treating ourselves like robots, right? But we're not robots. We have emotions, all of them, right? So, and that's okay. And so it's being able to understand, like, I don't have to avoid my emotions. I can build tolerance. I can experience these things. I can experience fatigue. I can experience anxiety. I can experience an urge even to engage in my BFRB. And I don't have to always react to that urge or to that emotion in the same way. I can slow myself down and I can respond differently. And that's what we do through the self-monitoring, through the functional behavioral analysis, and then to start to implement skills. And part of the skills, kind of something that DBT does such a nice job of, is going over like the emotions wheel with people, talking about different feelings. When do those feelings come up? How are you experiencing that? So, and then forming a different relationship. And like Dr. Deibler said too, it can be both and. I can have a stressful day at work or, be fighting with a friend or whatever the situation is, and still take my dog for a walk and enjoy that, right? So I can have an urge to engage in a BFRB, or having just maybe engaged in a BFRB, and I can still go out to dinner with friends that night, right? So it's something that I still want to engage in my values-based behavior, which is really living life kind of like we learn in doing ACT, acceptance and commitment therapy. What are your values? How do you want to show up? And then what are your struggles? What are the things that pull you away from those values? And so it's being able to really monitor, like, what do I want out of life? And how does my day actually look? And I think so often we're just doing the grind. We're not, doing what we need to do that really makes us feel that way. And then we notice these BFRBs showing up as an attempt to try to, create a more comfortable state, even if it's short term.
I really like how you're noticing that it can be about, right, that a BFRB can happen in the context of just, I'm stressed from the end of my day, or it can be maybe something that occurs when there's a more intense trigger happening, right? But it can just become a way that people are coping or maybe not, right? It's a form of coping that is maybe similar to scrolling on Instagram in some ways, right? And I think we've probably all had the experience of starting Instagram and then noticing, or YouTube, or, whatever your thing is, right? And then an hour later, you think, oh, where did that time just go, right? And I think it sounds to me like it can be a very similar experience. Another, just to kind of take us on a little bit of a turn, someone asked about the role of the caregiver. So if you have a child with a BFRB, how can you as a caregiver support them, and both do's and don'ts?
Caregivers have really important roles in the lives of individuals who have BFRBs. First, because they can be really helpful, but also, importantly, because they can unintentionally be harmful in that their well-intentioned behaviors toward those individuals and toward their BFRBs can unintentionally cause maintenance of the behavior or even exacerbations of the behavior due to the interaction between them. So one of the things that we address in the book is the importance of interpersonal relationships and learning good communication, right? Because not only Can a BFRB come between individuals, regardless of their kind of relationship, whether it's a parent and a child or whether they're spouses or friends? Not only can it become a barrier and a challenge between the two individuals, but it can also lead to potentially, more helpful relationships. And so one of the things that we do is we help really kind of bolster an individual's ability to engage in interpersonal effectiveness. Lots of times individuals become really embarrassed about the behavior, and it's a barrier in the relationships that they have with other people. And so they sort of lose the ability in some regards to become effective communicators because they're no longer confident in their ability to engage with people, whether it's directly about their BFRB or not. It might simply be, because of what's going on the inside, they're doing things like opting out of, interpersonal interactions and social engagements. And so we help people to learn how to engage more effectively with individuals, how to ask for what they need, how to say no, thank you to certain behaviors that might be unhelpful, how to redirect that. Here's what I do need from you. Here's what would be helpful. Because that's really important. And one thing that's, I think, traditionally really been missing from treatment is how to deal with the loved ones in your life. And for caregivers themselves, we find that oftentimes it's really important to have a bit of a psychoeducation session to help them learn the kind of do's and don'ts, right? It's really helpful when you can communicate confidence in the ability of the loved one who's struggling with a BFRB in their ability to tolerate difficult moments, right? I know this is really hard for you, like we learned from space, right? If anyone's familiar with space, right? I know this is really hard for you, but I know you can manage this, right? Not to jump into to save them from it or intervene in some way, but to say, I know this is hard, but I also know you've got this. And especially if it's a parent, right, to provide the resources in order for them to learn to manage this effectively on their own. And to also understand that, helping them and supporting them might look different from one person to another. Some individuals might want their caregivers to help bring attention to the behavior, right? Please let me know because I engage in this behavior sometimes outside of my awareness, and this is really helpful. If you could just hand me or tap me on the shoulder or do something to just sort of bring it into my awareness, that could be really helpful. And then we have other people who say, I don't even want to talk about it with you. I just want to be left alone to kind of manage this on my own. And neither one is wrong. It can be helpful, either way, or harmful potentially either way. So it's important to encourage a dialogue between the individuals. What might be helpful for you? What don't you want out of this? And to let them know that oftentimes when we're engaged in a little bit of a reward system between parents and kids, that it's really helpful to be able to shape the use of skills and strategies rather than punishing or overly focusing on engagement in the behavior or non-engagement in the behavior, right? We don't want to reward refraining from the behavior for the, so-and-so number of days. We want to encourage the use of skills. And if we encourage the use of skills and reward the use of skills and strategies, then hopefully we'll see a decrease in the behavior as a result. But focusing too much on whether or not someone has engaged in the behavior in a given moment can actually backfire and become more problematic. So it's really important to provide a little bit of education around that and to start a dialogue about what would be helpful or unhelpful to each person.
Thank you for that. As a follow-up question, you mentioned the space treatment, which is something we offer in my group as well, but I think folks are who have not already participated in that approach aren't quite aware of what it is. So I'm wondering if you would like to maybe just elaborate for a minute or two on some of those ideas, because I think certainly in this context it does relate, right?
Yeah, absolutely. So I think there are a number of concepts from space that's supportive parenting for anxious childhood emotions. It's a parent-based or caregiver-based intervention for anxiety disorders specifically, and could be used for OCD as well. Now that OCD has grown up and has a disorders category of its own. But some of those concepts I think are really important, cross-therapeutically, right, cross-diagnostically, and some I think are important for BFRBs as well. One is to provide helpful support, right? So the concept of being able to support someone without accommodating, without solving the problem for someone or stepping in, but rather providing them with the confidence and support that they need to hear from a loved one in order to be able to move forward, right? So not, oh, you're going to be fine, this doesn't matter, no one will judge you, you know, you'll kick this one day. But instead to say, I know this is really tough, I can see that you're really struggling, but I know you can manage this. And, you know, we have the tools to help you do that. So learning to kind of craft that support, I think, is really important. And there are times when we have to sort of work on reducing accommodations like one would through the space intervention. There are times when we have to, right? So for example, if a young child pulls their hair, and one of the things that distracts them from that behavior is being actively engaged in the use of an iPad, for example, because their hands are busy and they're clicking around, a child could potentially, you know, want a little bit more iPad time, right? Like who doesn't, right? So in the backseat of a car, for example, if a parent observes a child maybe pulling or whatever, to give them the iPad as a means of a strategy might be helpful, but it might also be harmful. And so we want to talk about the healthy use of strategies and skills, and over accommodation, which might unintentionally reinforce behavior patterns that we don't want to reinforce.
Thank you for that. So I heard what you were saying about how strategy can be both helpful and harmful, which I think is something we talk a lot about also with OCD when we talk about something an exposure or something a reassurance. And you know, sort of similarly with BFRBs, are there times where something might be a strategy that's an intervention that's a helpful intervention and maybe, you know, helps people not pick, but might also be something that encourages it in a different context, perhaps. Or if not, then that's okay too.
I think, you know, and this just really speaks to that individualized treatment. So, because even things that Dr. Deibler and I talk about as like low-lying fruit, as far as like therapeutic interventions, might be to use a sensory strategy, right? To give everybody a koosh ball, right? So, but that's an overly simplistic view, and not everybody likes that. Some people really, you know, that can be a trigger for them. So, and something that just kind of, they get more of a heebie-jeebie feeling off of that. And especially with neurodivergence and things too, we have to consider those individual factors and not just assume like a one-size-fits-all treatment. So we have to look at those particular needs, those different sensory preferences that people have, and then we can decide what to do with that, right? So depending on each individual person, I know that there's been a couple questions about urge surfing too. So, and with urge surfing, we're trying to build tolerance, much like, you know, OCD, we're building emotional tolerance to stimuli. That's what we want to do with BFRBs. In a slightly different way, but being able to notice like, okay, I'm having this urge, and we'll practice first by, you know, experiencing an itch or something, you know, so if I assess right now, like where on my body do I experience that, you know, almost always we're going to find something like, ooh, my leg, but then let's just monitor that rather than just react and scratch that. Let me see where that goes. Oop, now it jumped up to my shoulder, now it's at my nose, you know, oops, now it's down on my feet, now it's up on my forehead, to kind of notice how those sensations might bounce around a little bit, and I can build tolerance to that. I can sit with that for a little bit and noticing it come and go. And that's where like metaphors like leaves on the stream and things like that can also be helpful, that I can surf that urge, I can experience that without reacting in a way that's maybe not so helpful, like scratching poison ivy, right? So it's something that I can experience, that I can build my confidence in my ability to experience that without reacting the same way. And that's why having supportive people in our lives to be like, I know that this is hard. Yeah, it feels good to scratch poison ivy, right? But you know, you have other things, you have other tools. What else can you do instead that's going to give you, you know, the long-term result that you're looking for? And so I think that there's a lot of things that we can do with each individual to kind of, you know, again, identify and break those patterns.
I hear in there an answer to one of the other questions, right, which is mindfulness helpful, which is absolutely what you were just saying. So just to kind of anybody's still wondering, that's 100% true, it sounds like.
Yeah, and we almost always, Dr. Deibler and I, do end up doing some sort of mindfulness. I think that we, again, just as humans, we end up getting so checked out, right? So we kind of forget what our human needs are. And I mentioned earlier that BFRBs seemingly occur, across species. And we see it a lot in like laboratory animals, zoo animals, right? So because they're not living in their natural environment. And when we look at our own human existence, we got to live in zoos, right? So it's something that we're not doing as much as we need to. We're not touching grass, right? Being outside, sleeping, eating foods that are healthy for us, things like that. We kind of fall out of line. So it's really important to be able to utilize mindfulness, to be able to say, how do I actually feel? What do I need? Am I tired? Am I hungry? Do I have to go to the bathroom? Right? Like just these things that seem so basic, but we've kind of learned to override those needs. And guess what? Our body's still going to try to alert us to those needs in other ways. And I think that oftentimes is the function of a BFRB.
What do you think about the sort of, I guess maybe, I don't know if we know enough about the genetics of the origin, but the things that you're talking about are they're true for all of us, right? And while I would say everybody does some grooming, right? Not everybody has a BFRB. And so I'm curious what we know, or what you think, if we don't know, about why some folks struggle with this more than others.
Well, what we do know is that there's a lot that we don't know, right? The studies on, the underlying physiology of this is really still in its infancy, right? We have a few genetic studies, both in humans and in some animals, such as mice, that suggest that there may be, although it hasn't been identified in humans, there may be a grooming gene that has essentially gone awry in individuals who wind up developing a body-focused repetitive behavior. Because as you mentioned, right, we all groom. We all do this to some extent. And if you think of grooming in terms of a continuum, right, everyone picks their skin, for example, everyone, right? We've all picked at a scab. We've all picked at a bump or a blemish, right? But when individuals wind up spending a significant amount of time, effort, it's negatively impacting their daily life. Maybe they're having, medical consequences like infections, and it's taking away their time from time that they could be spending in other ways, that they'd like to be spending in other ways. Well, then at that point, it may actually meet criteria for disorder, right? There's a continuum. And at what point that crosses over into that line of, clinically significant distress or impairment is really kind of up to each individual's perception in terms of their experience. But in terms of the underlying sort of medical model origin, right, there is likely to be some genetic foundation, right? We know from twin studies, for example, that although again, only a few studies here and there with any of this in terms of BFRBs, we know from twin studies though that they do occur more frequently in first-degree relatives and in identical twins. So we know that there is likely to be an underlying genetic basis for this. And there are a handful of imaging studies that suggest some differences in terms of structure and function in the brain. It's really kind of unclear though, but it gives us some window into the idea that for some people, as with other kinds of behaviors that become, reinforced, that are difficult to stop, that there are probably reward centers in the brain that are lighting up a little bit more with individuals that have BFRBs, a little bit more responsive, a little bit more, nervous system response to these behaviors that's continuing to contribute to, the reinforcement of the behavior pattern and the difficulty that they have in struggling to stop.
Thank you. Do you find that there is, so I was certainly trained that there's a relationship, maybe genetic relationship, as sort of it travels with OCD. And I know you've spoken that there's a comorbidity there. I don't know if that's been backed up in the twin studies, but I also had a question from a participant around sort of other types of things where folks maybe have trouble with impulse control, such as addiction or substance use. And do you think of that as a separate category, or is it related?
I think that's a great question. I think when it comes to research versus real clinical practice, you're looking at two different groups oftentimes. So oftentimes to be a participant in a research study, comorbidity is kind of screened out, right? Like you can't have depression, you can't have an anxiety disorder, you can't have a substance use disorder. So in some research, right? But that isn't typically what you see and who walks into your office. We're usually built pretty fancy with fancy lives, right? So very rarely do we fit neatly into any one category, right? So research doesn't always represent what we see in the office. So, and again, like we've mentioned before, comorbidity is oftentimes there. I think it's like 70% of the time we see people presenting with a co-occurring condition in addition to their BFRB. That being said, it doesn't mean that it's always going to be there either. It doesn't always indicate trauma or an anxiety disorder or depression or anything else. So that's why we do have to individualize, treatment for people. And as far as like some of the studies that have been done, some of the neuro imaging studies, that BFRBs look a little bit more like tic disorders than they do OCD in some of that research. We got a lot more still to learn on these things, but it's something as far as research goes. But I do think that there is this strong biological bases, and like most conditions, we have these predispositions. And then it's looking at the role of hormones and environment and a lot of other factors that then lead to this emergence of these behaviors. So, and with BFRBs, they just like us, they're complex. And so it's trying to determine, well, why is it that BFRBs oftentimes start, during this age? But then why do most mental health conditions, begin in childhood and adolescence? What's going on with our developing brain and our developing hormones and our microbiome and all these different things, right, that we have to consider. And with young people now, the environmental factors with sleep and screens and things that we don't even completely understand yet either. So there's a lot more still to learn. That being said, there's a lot of great interventions that we can do right now too to improve treatment outcomes, starting with the monitoring, starting with mindfulness training, being able to look into yourself, just being curious and kind, right, to oneself, and using empathy and compassion, I think goes a long way to being able to kind of understand, like, what's my algorithm right now? What do I need? What is this this growling in my body, this BFRB trying to tell me? And I think when you're a loved one of somebody experiencing a BFRB, it's like, having kind of that same curiosity, again, depending on what's right for that person. But if you're working, you have a young child with a BFRB, it's like, okay, let's approach this with that curiosity. Let's approach this kind of like scientists, and how much involvement should I have? If they have a good clinician, they might not need much, it's kind of taking the therapist's lead a little bit and the child's lead ultimately on, what's going to be helpful here, and is now a good time, and, what strategies are going to be useful for you. So, and how do we monitor that, and how do we make treatment fun, right? Treatment, it should not be punishment. So it should be something that it helps people to kind of understand, be curious, try some things, and let's reward those efforts. And Dr. Deibler, and I just want to emphasize this point, in the past, I've worked with families, and again, good intentions. I love the parents that I work with and all of that. But we all get misguided as parents. We all have been guilty of being like, knock it off, stop it, put your hand down, right? That doesn't tend to help. Right. I get it as to, it gets frustrating in a lot of ways to be a parent. I have a 12-year-old myself. I can empathize with that. But it's something that it's being able to look at, well, what actually works and what doesn't? How am I doing with my own self-care as a parent? So my fuse is a little longer to help my child with those things. But also, to be able to use some of those space skills, I think can be very helpful. Reinforcing the use of skills, not like how many hairs, what do your nails look like? What does your skin look like? Because that can change really quickly. It only takes a few minutes to clear out eyelashes or to clear out a spot of growing hair, right? So we don't want to make the rewards on that like, oh, if you grow your hair back, I'll take you to Disneyland, or use things that are meant to be motivating, like, oh, look at your picture in second grade and how cute you were then, right? Like that's probably just going to increase feelings of shame and guilt. And shame, guilt, punishment doesn't tend to change behaviors. So we want to reinforce the use of these things that are be like, oh, wow, I saw that, when you sat down to watch TV, you changed your body position, or you got up and walked away, or you came to me and said, hey, you know what? My trichotillomania is really showing up right now, or I noticed I really want to pick. Can I get a Band-Aid? And, like those things can be really important. Or maybe I should tell you about what happened at school today or at work or whatever. And so it's utilizing those supports. Where they're helpful. Not everybody can be a support person. And that's the other important thing too, is to recognize, as a caregiver, what am I capable of and what am I not capable of? Some people just kind of naturally do better. And part of space sometimes means pulling in grandpa or grandma or an aunt or a teacher or somebody else into those supports too. So, and I think that's also something to think about. But we do want to be reinforcing the use of skills. We want to use that self-compassion and compassion toward others. We want to use that curiosity. We don't want to use punishment. And in the meantime, we still want to be living our lives, the best life that we can have, so any of us, right? BFRB or not. And so I think that's what we focus on, is mastery and enjoying our days and spending time, with the things that truly give us purpose and make us feel, more fulfilled.
Thank you. So don't be the trick police, do praise skills and good coping, and sharing of emotion, right?
Absolutely.
I know I'm mindful we have about 10 minutes left. So if there are things that either or both of you have that you want to make sure that if there's a question that you've been thinking, we didn't get to this, but I want to speak on that. And I also want to make sure that we have a little bit of time to talk to folks about how to find help. So I know some people said, my doctor won't diagnose this, or, kind of where can I go? And your book is probably a great starting point, I'm guessing. But if you have any other thoughts about how to get help.
I think there are a lot of really great resources out there, and the kind of resource that you're looking for probably depends on the kind of support that you need, right? So for example, if awareness training would be helpful for you, Habit Aware is a great device it's awareness training device that has a great companion app for people to use. And that can be a really great resource for people. Also, they provide some online supports for parents and other groups, so some support groups and things like that. So Habit Aware can be really great. There are other kinds of resources out there, like someone mentioned Picking Me Foundation earlier, and I believe Lauren is here on the webinar. Hi, Lauren. That's a really great resource. The website is really great, lots of great opportunities for education and support groups and such on there. There are other kinds of websites all over the country, and actually internationally as well. There's a BFRB UK organization. There's one in Italy. So there are places sort of popping up as a means of kind of being the resource kind of support hubs for people, to give them education, to provide them with reliable resources. So I think that there are a lot of places that you can do. Actually, YouTube is a really great place now too, to get some resources. ADAA has done webinars and such that are available on YouTube. There are online trainings. I know we give an online training. It's 10 hours for individuals seeking to bolster their own BFRB treatment skills. There are some great books. I think there's a lot out there available for people of, whether it's someone struggling with a BFRB, or whether it's a parent, or whether it's a treatment provider looking to expand their knowledge of BFRBs. I think there's a lot out there.
Yeah, and somebody had mentioned BFRB Changemakers too. They have some upcoming trainings, one of which Dr. Deibler and I are doing, and others too. So, and I think they're doing a good job too of balancing different perspectives. And again, I think that that's great. And you know, like I mentioned, Dr. Deibler and I are trained in integrative models. The treatment for BFRB started with habit reversal training, which was the treatment for tic disorders, which involves what's called usually the components are like monitoring your behavior, doing what's called a competing response, so a behavior that's incompatible with picking, pulling, biting, which might include like fist clenching, right? So it's a very behavioral model. And then we've seen this evolution happen. And Dr. Deibler and I have been doing this for 25 years, so we've been a part of this. And luckily, our training early on was in integrative psychotherapies anyway. So we're trained in psychoanalysis and family systems and cognitive behavioral and Rogerian and all these different treatment approaches, the trans-theoretical model, how people change, readiness for change. So, dialectical behavioral therapy ACT. And so I think that it's nice to have all those tools depending on what people need. So, and as clinicians and as consumers, when you're looking for clinicians, you know, it's finding people who have that kind of curiosity too. So, and even though I've been doing this for a long time, there's still so much more, you know, to learn and develop those skills and be able to really kind of get a complete functional behavioral analysis. So we're not just like, I don't know, try this, try that, because that gets really frustrating after a while. But it's like based on what seems like right now the function of your BFRB, that's what I think is this particular skill I think is going to be important for you. Like Dr. Deibler said, maybe some interpersonal or addressing shame or, you know, learning some other emotional coping skills, or, you know, there's so many great things that we can help people work with, so that they can live their best life with their BFRB and decrease the behavior as well. So yeah, there's so much to discuss. Like Dr. Deibler said, we have a 10-hour training, and even in our 10-hour training, we're like, there's so much more. So, but we do in our book too. We met our maximum limit of pages with our publisher, because there's so much to say and so many things that we want to share with people from our, you know, couple decades of really specializing and working with people with BFRBs. And the people with BFRBs have been our greatest teachers, you know, on being able to learn more, find the training and the skills that we need to better serve the populations of individuals that we work with.
I just wanted to add, there a few people are asking for a list of resources, and I can visit with you all after. There will be a post-webinar email that goes out to all of our attendees, and whatever I can include in that, and of course direct them to the book and to our website. Any last comments, guys? It was wonderful. Dr. Gordon?
I just wanted to say what a pleasure and honor it's been to get to speak with two such accomplished clinicians and researchers on this topic. I treat BFRBs, but I feel like I still learn more. There's always more to learn, and it was a great time. I think everybody gained a lot from being able to be here with you.
And we'd like to thank you for having us and for addressing this topic. It's so under-addressed, and it's much appreciated that you took the time to offer this for people.
Well, I'd like to give a shout out to Stephanie Woodrow, who worked with ADAA to bring this to our audience, and to thank you both so much for sharing your expertise, and for Dr. Gordon for moderating today. We're wrapping up, so I just wanted to say a few things about the Anxiety and Depression Association of America. Works to prevent, treat, and cure anxiety disorders and depression through the alignment of science, treatment, and education, like webinars today. We invite you to explore our website at adaa.org, where you can find resources such as Find Your Therapist directory, free evidence-based webinars, blogs, and videos, our free online peer-to-peer communities, self-help books and publications like the one we talked about today, and also to ask that you consider subscribing to our free monthly newsletter, Triumph. And on behalf of ADAA and all of our presenters and moderators, we thank you so much for joining us, and we'll see you next time.
Thank you.
Thank you. Bye-bye.